Over the past few decades, many patients have benefited from arthroscopic-assisted meniscus repair surgery. However, the basic premise of central to peripheral needle penetration across the tear, with fixation into the capsular region immediately peripheral to the meniscus, has remained. Recent technological advancements may give surgeons a unique tool to improve outcomes and possibly broaden the spectrum of what can be considered repairable. This presentation will discuss the basic premise of the circumferential compression stitch and provide some clinical examples of its utility and feasibility. In disclosure, I am founder and Chief Medical Officer of Stitich Orthopedics and a consultant for MoxyMed. Peripheral vertical tears are among the most commonly repaired tear patterns because of the comparatively good peripheral blood supply and the presence of a large central meniscus fragment that is necessary when utilizing typical central to peripheral vector repair techniques. These techniques typically lead to good compression of the tear in the region of repair, but sometimes lead to poor compression or gap formation in the tear regions that were not directly repaired. They can also cause distortion of the central meniscus fragment, sometimes referred to as puckering or buckling, and the capsule can be incorporated into these repairs to some extent, which might cause tightening of the perimeniscal capsule and has been shown to potentially cause shrinkage of the functional meniscus surface area. Inherent risk for neurovascular injury also exists. Because of smaller needle diameters and the fact that a meniscal remnant is not necessary as a backstop, inside-out meniscus repair may more reliably achieve fixation at the superior and inferior tear surfaces to provide uniform compression. However, it is more invasive, has neurovascular risk, and it utilizes the same central to peripheral repair vectors. The circumferential compression stitch encircles the tear via an all-inside technique that may provide uniform tear compression at the superior, central, and inferior tear surfaces, regardless of the obliquity or orientation of the tear, and deliver a morphologically anatomical repair. It was also shown in a laboratory study by ASIC and Center in 2002 to have the highest load to failure of any repair pattern. So to show how the repair is performed, I'll start with a brief animation. Varus or valgus stress is applied to the knee, and the Stitich device is inserted via the inframedial or infralateral portal. The device is advanced atraumatically into the peripheral region of the desired compartment until the upper jaw is located between the femoral condyle and the superior surface of the meniscus. The lower jaw is then extended underneath the meniscus, and the sutures pass from lower jaw to upper jaw, where the suture is self-retained. The device is then repositioned, and the second pass is completed. The lower jaw is then retracted, and the device atraumatically removed. The sutures are peripherally tied and cut, and the stitch is complete. Because of the optimized needle trajectory of this device, it's likely to significantly decrease risk to neurovascular structures. And it can be used for repair at the level of the popliteal hiatus if desired. The knot can be tied on the peripheral femoral side, and as the knee is brought into flexion, the capsule falls away from the meniscus with the knot. Or it can be tied on the peripheral tibial side, beyond the edge of the tibial plateau within the gutter. It can also be switched out for absorbable suture if desired. And so here's an arthroscopic image of a repair in which the sutures were shuttled down to the tibial side, and you can see the two tails of the suture coming off to the right, and the circumferential compression stitch going over the femoral surface in this case. This was the second of 3 stitches that were placed to complete this repair. And here it is after it's been tied on the peripheral tibial surface within the gutter. And notice that we have uniform compression of the tear, and there's no shrinkage of the meniscus, or as I sometimes say, there's no iatrogenic extrusion, and you have restored excellent meniscal morphology after the stitch has been placed and tied. And so the first clinical example is that of an active 50-year-old female with a symptomatic peripheral tibial-sided medial meniscus tear. This was a peripheral tear that exited the tibial surface of the medial meniscus in an oblique fashion. Treatment options include total meniscectomy, partial meniscectomy, or repair. When repairing with this technique, the idea is to encircle the tear and anatomically compress the tear edges during healing. A rasp is used to stimulate a healing response, as is standard technique. Stitich device is brought in through the anteromedial portal. The upper jaw is 1.25 millimeters in thickness presently, and it fits nicely following the contour of the femoral condyle. The lower jaw is extended underneath the meniscus, needle trigger pulled, lower jaw retracted, the suture self-retained in the upper jaw, and the device is removed atraumatically. The second pass is now placed more centrally. The upper jaw is positioned between the meniscus and the femur. The lower jaw is extended underneath the meniscus. The central pass is made, the lower jaw is retracted, and the device removed, with the suture following suit. And then in this case, a knot was slid down to the peripheral femoral surface and tied with standard techniques and cut. Alternating half hitches were placed. Then upon probing, it was determined that an additional stitch would be optimal. So the device was brought back in, lower jaw extended underneath the meniscus. Anatomical compression of both the femoral and tibial surfaces. Lower jaw retracted, suture self-retained in the upper jaw, and then reinserted for the central pass. Optimal location and targeting. Once I've determined that, pass the suture with the pull of the needle trigger, retract the lower jaw, and pull out.